ECHO series. A special thanks to our collaborators, Hawaii Emergency Management Agency, Healthcare Association of Hawaii, Hawaii Association of Directors of Nursing, and Hawaii Medical Directors Association and Mountain Pacific Quality Health. We usually have a brief presentation, then we open up for a time of questions and discussion up to about 3 p.m. We ask you to use the chat box to submit and queue up your questions. We will be offering CMEs that nurses can use for CE purposes as well, and we will also offer certificates of attendance to all participants who complete an evaluation. And if you haven't already registered, you can still do so after this webinar. Evaluations can be found on our website under the Evaluations tab or following the link in the chat box that Michaela will put through there. At this time, we ask you to enter the names of all the attendees in the chat box for attendance purposes. And for those of you calling on the phone, it would be great if you could unmute yourself, tell us your name, or text your name in there. So today, actually, let me see if we have in the participant list, do we have lots of phone people calling in? We actually do have just a few phone people calling in. Anybody want to unmute themselves and tell us who you are? Okay, you guys are shy. All right. Okay, so today we will have a session on COVID testing updates, and we have Sarah Kemble. Dr. Kemble with the Division of Communicable Disease at the Hawaii DOH, and she will discuss a whole bunch of things, pros and cons of universal testing, point prevalence, testing, hospital clearance, all kinds of things. So we really look forward to this presentation. We're actually looking forward to anticipating a lot of questions. I just want to mention, so we have, I think we have do we have a slide on, the schedule, upcoming schedule. I know we whizzed through that one really fast, but basically next week we have a session on COVID support for Medicaid and LTSS patients. And hopefully we will be hearing about how MedQuest is supporting patients in different long-term services and support settings, such as, you know, the care homes, the family foster homes, and the community home-based care, and all those things. So if you are caring for patients in those settings, you may find that informative and helpful, and we hope to see you next week for that. And then after that, we'll be talking about protecting protocols and strategies for protecting home care providers. And we have somebody from the Visiting Nurse Services in New York City. So that's going to be super exciting. Okay, so without further ado, I'm going to let Sarah Kemble go ahead. Thank you.
Thank you, Aida. All right, so I'm going to talk about COVID-19 testing in long-term care settings, and I hope this will also be applicable to assisted living and settings beyond the skilled nursing facility. Next slide, please. So the very first thing I want to start out with is just a reminder about important numbers. So before a case ever occurs in a facility, these are the things that you need to know to be prepared. Know what number to call to report a COVID-19 case to Hawaii Department of Health. These are all of our numbers here. We can distribute these again in other ways too if people don't already have them. They're also available on our website. The other point that I want to make is that if you haven't already sent to the Disease Outbreak Control Division Healthcare Associated Infections team the contact information that you want us to have for your facility, if we have to call you ever with a case notification, please email it to Caitlin Cook, caitlin.cook@doh.hawaii.gov. Caitlin is our HAI epidemiologist team lead and keeps our contact list for when we have to make urgent calls. And this is more important than ever now. You don't want to have any delays in us reaching you if we have to notify you about a case. Next slide, please. So this talk is primarily about testing, but as I thought about testing, it doesn't stand on its own. And so I think it's really important to remember what are all the elements of a COVID-19 response plan. And it really starts with your infection control measures for prevention and mitigation. That's the core of any response plan. Other pieces, which we've talked about on some of the other webinars, include active symptom-based surveillance of residents and staff and testing of those who meet symptom criteria. Exclusion and isolation policies, so knowing what you're going to do if you have a suspect or confirmed case. Having plans around PPE supply and usage, and knowing what your supplies are and what your needs are going forward. And then finally, as you put all those pieces together, the testing plan becomes part of the picture as well. Next slide, please. So when I talk about COVID-19 testing plans, there are several scenarios that need to be considered when you think about different plans for testing. So one is just the most core piece of this, again, is your active surveillance for COVID-19 like illness, and how you plan to test, who you plan to test, and how you plan to test them when somebody meets your criteria for that surveillance. You also have to have a plan for what is your response to a case identified at your facility and what kind of testing ensues as a result of that. And then finally, we'll talk a little bit about when there is no known case at your facility, but you want to have some testing plans in place around just baseline surveillance. Next slide, please. So reminders about active surveillance for COVID-19 like illness. This really should mean testing staff with any symptoms compatible with COVID-19. This would apply to visitors as well. And that is including but not limited to cough, shortness of breath, fever, whether it's measured or subjective, chills, rigors, mild or body aches, sore throat, loss of sense of taste or smell, headache, runny nose. So this is really a much more extensive list than we're used to thinking about for instance, flu screening. And so the bar is really quite low to test anyone who has any new symptoms develop that might be compatible with COVID. And then beyond that as well, when you're talking about residents, and Dr. Wen has brought this up on multiple webinars as well, there are other things to look for in residents who may not be as easily able to tell you about their symptoms. So a change in mental or functional status can be enough to order a test. A change in vital signs can be enough to order a test. So we're really talking about a very low bar for active surveillance. But this process of paying attention to what's going on in your facility in terms of any change or patterns of symptoms can be a really important way to identify a problem early. Next slide, please. So what if there is a case at your facility? These are some of the initial steps involved if you have a case. The very first thing is going to be notification. And this should be a verbal or warm handoff, not a voice message, not an email. We want to make sure that we really reached a live person on the other end. And this can happen in either direction. The Department of Health does get electronic laboratory reports, so we may get notification, initiate the case investigation, and find out that the case works at a long-term care facility or other long-term care setting. In the reverse, it may be that the facility has an employee or a resident who tests positive. Maybe the employee will notify you, and it's sometimes possible that the health department has not yet been able to reach that person, and you might be the first to find out. So it's important that we each have each other's emergency contact numbers so that that initial notification handoff can happen. Once the notification's there, the investigation begins, and this is the classic contact tracing story. But in a facility, this can involve a lot of initial information gathering. So there are some things that we'd like you to know we're going to be asking for right away from the public health side as part of an investigation. That's going to include, at a minimum, the case's location, room number or work location, their symptom onset. There's looking at census to determine who else may have shared shifts, what residents they may have cared for if they're in a patient care role, staffing schedules to compare among coworkers who might have interacted, looking back at symptom logs, looking at absenteeism, and looking at patients who may have transferred out to the hospital. So there's a lot of things that kind of get thrown at you when a case happens. And I think a lot of times people are jumping straight to the testing, but I think it's really important to remember that the next one I'm about to talk about, infection control, the mitigation measures, is actually probably the most important step in this process, other than establishing the initial facts of the situation. And that's because it's what you do with your infection control that's most immediately going to stop the outbreak. The testing will come, but it's actually this piece that does the most to prevent spread. And then there's communication considerations, both communications with public health and other healthcare partners, but also in today's climate, there's almost certainly going to be media communication involved, and preparing of press statements and those types of things. And then finally, testing is almost the end of that list. It's important, but these other things also really have to happen very quickly. Next slide, please. So in response to a case at your facility, one of the first things will be testing residents and staff who had direct contact with the case or resided or worked on the same unit as the case in the 14 days prior to the case's symptom onset. Co-workers who may have shared break room space with an employee case should also be tested. But this is the testing strategy, but I want to remind you in terms of exclusions or quarantine, it's only the close contacts of a case that require quarantine or exclusion from work. And what is a close contact again? That's someone who was within 6 feet of a confirmed COVID case without protection for 15 minutes or longer, or for any length of time during an aerosol generating procedure, or who had unprotected direct contact with infectious secretions or excretions of the person with the COVID-19. It has to be during their infectious period, so that's 2 days prior to the case's symptom onset, or of course after the symptoms began until the case is cleared. And so the close contact definition is really emphasizing a fairly intimate level of contact without protection. And that's the group that we're going to be the most concerned about following up for, of course, quarantining and then testing, but also following up for any development of symptoms, any potential for further spread from those close contacts. The rest of the testing on this slide is really more of an abundance of caution. If there's no close contacts identified, we still want to be sure that there were, we want to believe that everyone's practicing the right universal source control, the physical distancing, but we all know there can be lapses in that, even if they're unintentional. And so the broader testing is just sort of an insurance that we're not missing something beyond that. It doesn't mean that everyone who's tested needs to be quarantined, and I want to be clear about that. Next slide, please. So this is the testing plan checklist that you're going to be going through as you think about testing in any of these scenarios. First off is specimen collection logistics. Next slide, please. I'll come back to the rest on this list. So what are the logistics of specimen collection? It's a lot. You want to make sure that you have staff that are trained on nasopharyngeal swab collection. It may seem simple. We've done some of the videos on this webinar series, and I think it's a topic we'll continue coming back to, just because it's always good to keep practicing and making sure that your staff know how to do a good nasopharyngeal swab collection. We'll talk later about test characteristics, but part of having a sensitive test, meaning one that's going to pick up disease when it's there, is also doing a good job with the specimen collection. You have to think about who will order the testing. Most cases in skilled nursing facilities, it will be the medical director. We've talked on earlier calls for some settings that may not have a medical director on staff, some of the community care homes. That should be part of the plan that you develop, is thinking about who is going to be the person that orders your testing. Perhaps having a refrigerator on site for specimen storage. For smaller settings, this may be less of an issue if specimens can be collected quickly and delivered to the lab the same day. But if you have a very extended testing endeavor going on where you have to test hundreds of your staff, you might need to have storage for some of the specimens, so that's something to consider. Make sure you understand, I didn't put that explicitly on here, but make sure you understand which transport media you're going to be using and whether it requires refrigeration or not. There are different transport media, so knowing what your supplies are is also important. Do you have the staffing to complete the necessary paperwork? And then a line list of all individuals tested. This includes things like their unit or room, whether they are resident or staff role, specimen collection date, what the result is, and whether that person was symptomatic or not. If they were symptomatic, what symptoms did they report? That line list is going to be a really central thing that you'd share back and forth with public health, and helps us to guide you through an investigation and determine what the next logical steps are going to be. Next slide, please. Next on the testing plan checklist, what laboratory will perform the testing? We do encourage all facilities to include in their testing plan an identified clinical laboratory that is able to perform testing and that would have the capacity, if needed, to test all of your residents and staff within a 48-hour period. Next slide. That being said, we do have prioritization available for testing at state laboratory division, in particular for long-term care settings. Part of our emphasis here is also being available to facilities that do not have the resources in terms of staffing or supplies on site to do their testing, especially some of the smaller care home settings. We imagine that most skilled nursing facilities do have trained staff who are able to collect nasopharyngeal swabs, and we do to some degree rely on that, but we have backup plans if that were not the case. So SLD testing is going to be prioritized for groups of staff or residents who were close contacts of the case, or who were not close contacts but worked or resided within the same unit or area as the case. And so we may not be coming in and saying we're going to test your entire facility at state lab. It will depend on the initial findings and that initial exchange of information and what is going on with the investigation. But we will prioritize those groups that are deemed to be at risk based on the facts of the investigation. So based on the findings of the case or cluster investigation or initial testing, it's possible that additional groups will also be prioritized for testing at SLD, and that will be an ongoing conversation with the health department. State Lab is able to offer a 24-hour turnaround for results from the time of the receipt of the specimens in the lab until the result. I think the biggest challenge is with neighbor islands and getting the specimen to the lab. And so that's something we continue to work on. There are some options on the neighbor islands for testing on the island, and sometimes it is actually faster to go through clinical laboratories in some of those settings. So we'll work with you on that if you have a case and deciding what's the most expedient way to get results. And then facilities, as I mentioned, should also have a clinical laboratory identified with capacity to perform testing of all residents and staff. Next slide, please. We do have right now an option to deploy swab teams through DOH. So if a facility does not have trained or available staff to perform prompt specimen collection, the Hawaii National Guard is currently through HIEMA available to be activated for public health investigation purposes for swabbing. The HDOH Healthcare Associated Infections team can discuss this option with facilities when an investigation kicks off. And the teams can also be activated by calling HDOH at the numbers listed here. Next slide, please. So coming back to our checklist, we got through specimen collection logistics, what laboratory. Another important question to answer in your plan is, will the plan differ for residents and staff? So there may be differences in insurance status or providers for your residents and your staff. So you might want to think through how you would quickly get all of your staff tested, whether that's something you'd be able to offer on site, or would you send them to another site for that testing. Next slide, please. Who to test, and next slide, just emphasizing what will happen in response to a positive test. I think that the best way to answer these last two questions is to walk through some scenarios. And so I have a few scenarios queued up that we can go through. Next slide, please. So when the first scenario I have up here is when a healthcare worker with patient contact tests positive. So what's going to happen in this scenario? First is all this info gathering, because this helps decide what the most logical testing plan is going to be. And that's reviewing staffing schedules and assignments, symptom logs, compiling lists of patients with whom the employee had direct contact, reviewing PPE usage of the case and others around them in compliance with universal source control, asking about break room usage, meals, unmasked time periods, and gatherings outside of work. All of these are important. We don't always get all of this information right away, but getting some of the critical elements can tell us pretty quickly whether we're looking at a whole house testing scenario or just a unit. We look at cohort and quarantine of, the next bullet I have here is, in addition to thinking about those things for info gathering, you're also going to want to immediately implement cohorting and quarantine of close contacts to that case once they're identified, and institute precautions on the affected units. So in terms of testing, which is kind of at the end of that list of info gathering and infection control mitigation, what are some of the possible strategies? It might be, well, definitely would be testing any close contacts. That's a given. And then in addition to that, a DOH would recommend testing all residents and staff on the units where this healthcare worker worked. This is a scenario where you might end up testing your entire facility if the employee case floated frequently or works across the entire facility. And we've seen this sometimes with therapy employees because the nature of their work is to work on a lot of different floors. If you have a case in a worker who's PT or OT, you might end up having to test really quite broadly. Next slide. So scenario 2, when a healthcare worker with no patient contact tests positive. So what do we do here? Well, the same things to begin with. We're still going to want to know the staffing assignments, symptom logs, close contacts. Do they ever actually go out of their usual work area to the patient floors for any reason? We want to confirm that. Is there source control compliance in their work area? How do they spend their breaks and take their meals? And have they had gatherings outside of work? We would also want to quarantine close contacts to this healthcare worker. Possible testing strategies, definitely close contacts again. And in this case, it may be limited. It might just be staff who work in the same area as the positive healthcare worker because they are not seeing patients. They're not even in the same areas as the patients. It's just making sure that those who were sharing the same space are also tested out of an abundance of caution. Next slide, please. Scenario 3, resident tests positive after being transferred from the hospital. So immediate isolation in place or transfer to a COVID unit. And I'll come to, at the end, we'll come to what benefits there are if the patient was in a COVID unit. So same info gathering process on their medical history, prior testing. Was this a patient who was in recovery already, maybe already had a negative test, or is this somebody who was not yet cleared or was unknown? Looking at the census history to see if there were roommates or if there are currently roommates, reviewing staff assignments and PPE usage. We would quarantine staff with unprotected close contact, cohort resident contacts and roommates. And for the entire affected unit, there would be precautions instituted. There's some important questions about a resident testing positive. Are they ambulatory? Did they attend any activities, or were they partaking in communal dining at the time? Were they going out for services like hemodialysis? Those questions will really dictate how broadly testing needs to occur. So some possible testing strategies here, again, close contacts always. All residents and staff on the affected units or affected areas frequented. If the resident does go out for activities or dialysis or other services, it's more likely that we're going to need a very broad testing strategy and the entire facility may need to be tested. Just because there will then potentially be contacts on multiple floors and it may be harder to tell who could have been impacted. If they've been in dialysis and we're worried people could have been exposed there and then going back to other parts of the facility. In a post-acute, if this is where that post-acute COVID unit could really make a difference, because if you've had that set up and the patient was already on at least droplet precautions there, then you may only require testing of the post-acute cohort and staff, and you may not need to go more broad than that. So it really is about what kind of strategies you already had in place before the case presented. Next slide. Scenario 4, resident test positive de novo. So not coming from the hospital, but a resident fell ill on the floor, let's say, and you ran the test and it's positive. Now what do we do? Isolate the patient or place them or transfer them to COVID unit. Same review of data as for scenario 3, but this is probably the most concerning scenario of those I've gone through, because here we're wondering, we're all scratching our heads, how did this person get COVID? So again, close contacts are a no-brainer, but you're looking at probably testing all resident staff and floats on the affected unit or units, all residents with shared activities or services. And if their movement has not been strictly cohorted to one part of the facility for their entire 14-day incubation period, it's pretty likely we're going to be testing the entire facility and all the residents and all the staff. Next slide, please. So I'm sure there will be more questions on the scenarios, so I'll be sure to address those at the end. I do want to talk a little bit about what about when there are no known cases at your facility? Do we test? When do we test? How often? So DOH stands on this: in the absence of a known case within the facility, you can consider doing periodic point prevalence surveys, which is testing all or part of your residents and staff regardless of symptoms. However, it is not a recommendation of HDOH that you must do this at this time. We acknowledge the CMS guidance. We've also studied it closely, and it does allow for consideration of local and regional epidemiology. And with Hawaii's current epidemiology, we do not feel it is a helpful use of resources to do a baseline testing and weekly testing a priori without some kind of cause to do so. And that cause could be a case in your facility. It could be a change in community prevalence, where we now have widespread community prevalence in Hawaii. But at this time, with the very low prevalence we're seeing, we do not think this is a very good use of resources. Point prevalence surveys are more likely to be useful if community transmission is widespread. And I'll talk a little bit about why. So next slide. So this is going back to sort of epidemiology basics. This is talking about, this is a table looking at comparing the testing results versus reality when you do a SARS-CoV-2 PCR. And there's some assumptions I put into this table. Let's say your sensitivity of your PCR test is about 90%. Let's say your specificity of your test is very good, it's 99.9%. And your prevalence in your population that you're testing, oh, okay. So in this scenario, if we plug in the numbers in a population of 1,000 people, what we end up with is a positive predictive value. And positive predictive value is basically taking all those who screened positive by PCR, who actually had true disease, divided by the total who screened positive. So what is your positive test actually telling you? How good is your positive test? In this scenario, 90%, you have a positive predictive value of 90%, meaning that you have like a 10% false positive rate. Negative predictive value is 99.8%, so it's very good. So you can really trust your negative test in this scenario. Next slide. So let's change the scenario a little bit. Your population prevalence is now at 5%, your true prevalence. So in reality, 5% of people have COVID, and you test the 1,000 people. In this scenario, the value of your positive test has gone up because the underlying rate of true disease has gone up. So now our positive predictive value is 97.8%. So you're only getting about 2% false positives. And your negative predictive value, with this good a specificity, you're still doing very well. You have like 99.4% negative predictive value. So you can still really believe your negative test. Next slide, please. Let's say now we have half the population actually has COVID. Well, this really changes things. So if you run the numbers again out of 1,000 people, you're now looking at a positive predictive value of 99.8%. So if you have a positive test, you can pretty much believe that person is truly positive. If you have a negative test, you've dropped now to closer to 90%. So you're actually going to be missing some true positives with your screening. So when you're in a high prevalence state, testing becomes less reliable, but it takes a fair amount of population prevalence before you start to see negative predictive values this low. Now, this is dictated by the characteristics of your test and how well you perform it. So it's possible that the label on the test says 90% sensitivity, but in the real world, it might be lower, it might be 70 or 80%. So those are other caveats. Next slide, please. And this is just a table to kind of show you at different population prevalence rates what your false positive ratio is actually going to be. And so this is more working backwards, where you start at a higher prevalence of 5%, so you have 2% false positives. And as you can see, as the prevalence in the population gets very low, you can actually have quite a few false positives show up. That's another important thing to understand about testing, because even though the PCRs that are available for SARS-CoV-2 are very specific, if you test enough people, you still will see false positives as well. Next slide. And then I just wanted to talk a little bit about epidemiology of COVID in Hawaii based on the data that the health department puts out daily at this point. And this is one of the curves that we watch to just look at overall disease in Hawaii. And this is median number of cases per day by MMWR week. And it did peak back in March and April, and then has been on the decline, of course, with the stay-at-home orders. And now for the last 6 weeks, we've been at a median of 1 case per day, with 0 in week 21, but still at 1 case per day over the last couple of weeks. So this is one way to kind of keep an eye on what the case rates in Hawaii are doing. Next slide, please. And another way is to look at the percent of positive tests out of all the tests that are being performed in the state. This is also available on the website. I have the URL here, so if people are interested in following this measure, you can actually break it down by county and see what the difference is for your county and see what the testing pattern has been. The chart across the top gives you a 3-day rolling average of the number of tests performed, and what the yellow shows you which of them have been positive. And then on the bottom, you have a percent positive ratio, so you can see what the percent positivity out of all the tests performed has been. Next slide. And so actually, before I talk about this one, the reason I show you those 2 charts is just to show you some of the kinds of information that we look at the health department to try to provide assessments of the community risk. And this is part of where we're coming from when we say right now community risk is very low. And it's based on a very low percent positive rate and the low median cases per day in the state right now. As CDC loves to say, this is a rapidly evolving situation, so I cannot tell you if the case count may shoot up next week or the following, or if things reopen. So we're always trying to be prepared for what may come next. But in terms of looking at where we've been to understand where our best guess is about where we are now, that's the data that we rely on. And this other slide I wanted to show you is some preliminary data that we've put together from some of our investigations so far with sporadic cases and clusters in healthcare facilities. And I think the main takeaway here is this is 3 different healthcare facility investigations with multiple units involved and testing that was done. And I broke it down by which units had universal masking in place at the time the testing was performed, and whether there was floating of healthcare workers between the units at the time the testing was performed. And the take-home point is really this units 1, 2, 3, and 4 did not have universal masking in place. And you look at the percent positive out of all those tested, in these testing sweeps, and we have some pretty high rates, up to 17% in Unit 2, and even in Units 1, 3, and 4, rates that none of us would be comfortable with. But looking at Units 5, 6, 7, and 8, 102 people tested on Unit 5 with only one positive. They had universal masking in place, and floating of healthcare workers between units was happening, but the universal masking was there. And Units 6, 7, and 8, we have universal masking and either minimal floating, or in one case floating, but no positives turning up. And this is sort of our best data to date from the state to show that the universal masking policies have really made a huge difference in how much transmission we would expect to see. So it's sort of the take-home point being here, trust in PPE and source control. It really does work. In some ways, it's more reliable than the testing. Next slide. And then one question that has been posed many times, so I will address it here, but we can certainly continue discussion on it. So are 2 negative tests better than 1? And the answer is it depends. So it really depends on why is the test being performed. If you're testing because someone is symptomatic, which is what the test is designed for, then 2 negative tests is really quite good, because even if you have an imperfect test that's not great sensitivity, you combine 2 of them, you're really reducing the chance that you have a false negative. So 2 negative tests in a symptomatic person is a pretty good indicator that you have a negative. Asymptomatic with exposure, so somebody who may be in their incubation period, is kind of the opposite end of that spectrum. So you can test them all you want on days 2, 3, 4, and they may be negative, and it's not a false negative, it's a true negative, but they may become positive on day 5. And that incubation period, that 14-day period, there's nothing we can do to modify that. And no amount of testing is going to change the possibility that that person could become positive the next day. If you're talking about somebody who's asymptomatic without exposure, then we're really getting into the point of some of those tables about sensitivity, specificity, and population prevalence. Because if you're testing someone who's had no exposure and no clinical symptoms, you are kind of, if you test enough of those people, you're going to have that false, either false positive or false negative results that are less meaningful. And so it's going to be, testing is going to be the most useful when you apply it to a population where you have some reason to believe that person could have COVID. And then with the known positive person who's recovering, 2 negative tests is a very good indicator that they are no longer infectious. What we're facing now is that many people will continue to test positive, and it still doesn't mean they're infectious. And that's the other side of the issue that we're dealing with. It's positive. How do you interpret a positive result, and what does it really mean? Next slide. So that is where I'll end my presentation, but definitely interested and available for questions.
Thank you. Thank you, Sarah, very much. We do have a question here, Dr. Dan Saltman. Some places report a functional sensitivity of only 70%. This can have to do with testing techniques, equipment, and the tests themselves. The positive predictive value is terrible for this scenario. What are your comments on that?
Yeah, it's very true. And that's why in the testing plans, we think it's important to both identify what laboratory you're using, because that's also related to what tests they are going to use. So it's both thinking about the test and the testing techniques, and then knowing that your staff are going to collect a good specimen, and then knowing that you know how to transport that media, whether it needs to be refrigerated or not, because if you leave it out at room temperature for too long, that may also reduce the sensitivity. So all of those factors play into the real world characteristic of your test.
Sarah, thank you. That was more a comment. Excellent presentation. Thank you so much, Sarah. So I did have a question. That was more of a comment on what you were saying about the positive predictive value goes down really a lot when you have poor sensitivity tests. But I have a question that's been nagging me the whole time that we report out sometimes in the newspaper. I see that we have the lowest rate of death in the country, and we certainly have a low number of deaths. It's still at 17 out of 650 or 660 something cases, but that's a case fatality rate of about 2.5%. Do you think that's the case fatality rate in the state, and how does that compare? And I know that's a hard number to get to, but how do you think that compares with the case fatality rate overall, with all comers all over the world kind of thing? Because case fatality rates have everything to do with which population you're looking at, of course.
Yeah. I think my first comment would be that our numbers are too small in Hawaii for that. I wouldn't put too much stake in the exact percent, because with small numbers, there can be a pretty wide variability in what the true underlying rate would be. That being said, it's similar to the early reports out of China in terms of mortality rates. And I'm not sure how it compares to New York City or other parts of the US. I think overall, just because we've had a low number of cases, we've had a low absolute number of deaths, but I don't think we can say that we've escaped, that the disease has been less severe here than in other places. Does that answer what you were asking?
Yeah, yes, and I still have more questions if nobody else is going to ask questions. I have a bunch of questions. But also you spoke to something about that too, that's the infection fatality rate. So that's a little harder to understand, but that has to do with an estimation of the infection overall in the community and how many people are dying. And those are kind of related questions. And that speaks to how deadly is the COVID virus? How deadly is this virus?
Yeah, and again, I don't think based on Hawaii's data, we'd be in a great position to comment on that just because the numbers overall are low, but we've certainly seen enough from other parts of the world to believe it's deadly enough to warrant the actions that are being taken. Yeah.
Okay, so we have a question from Alice Liu. Are there standardized templates for use to record the tracking and following of resident staff symptoms should we have cases? And I'm just going to throw out that actually last week we had a session on tracking logs. And if you go to our ECHO website and you can download resources, there's actually the Excel spreadsheet, and you can go ahead and just download it and use it. But
Yeah.
if you have other comments.
I'll add to that, that tracking spreadsheet was designed specifically for the line list you'd want to keep during an outbreak. Sometimes the symptom logs that you do for your daily checks may be a little bit simpler than that because you don't have the testing information and some of the other fields that we need on the outbreak line list. I've seen some good examples from facilities, so maybe we can work to get some examples up on our website too and through this forum. Just a resource center would be great for those types of logs.
Yeah, no, if you have a sample of the symptom log list, then we could just add it to that tab on the website.
Yeah, we'll work to get some resources out on that.
Okay, great. I was just remarking, noting that the percent positive rate, like you showed us that little graph in Hawaii, is like 0.1%, 0.3%, which is really super low. And so if you kind of extrapolate with your positive predictive value charts and things like that, this means that we have a very high false positive rate potentially. So
it speaks to the quality of the tests that are out there in terms of specificity, that we haven't seen a ton of false positives, but many of you, if you're following the daily counts and the news announces them, you'll hear that counts have been removed or put back, by the state. And that has everything to do with the test characteristics and having to follow up testing that comes in as presumptive and work with the laboratories to understand why it's presumptive and verify. And we have determined some to be very likely to be false positive results. And those have mostly occurred through the preoperative screening. or the pre-admission screenings that are happening. So they're happening in populations where there's really no known epidemiologic risk, and there are no clinical symptoms to suggest COVID. And that's exactly what you'd expect, is in those populations where you're testing without sort of due cause to believe that they would have COVID, you're going to see some false positives.
Okay, oh, here's another comment. We wanted to just confirm, is the state of Hawaii or DOH now requiring all nursing homes to complete COVID screening on their residents 3 times a day? I have not seen the recommendation from CMS. The last I heard is that CMS requires a surveillance program, but the frequency was not mentioned for well residents.
Screening. We've been encouraging 3 times a day, but it's really more of a per shift thing. So I don't know, maybe you can answer for me if most nursing homes have shifts, 8-hour shifts or 12-hour shifts?
It depends. Most have 8-hour shifts, but there are some that have 12-hour shifts. And I think we did a little poll the last week, and I think most of the facilities said that they did symptom screening 2 or 3 times a day. That was sort of the general consensus.
That mainly because things can change throughout the day, and I think that anytime you're coming on a new shift, it's kind of a good idea to know as you're coming on what the status is and not necessarily trust what the last person said. That being said, if that's burdensome, the CMS guideline is actually a minimum of once a day symptom screening. So we're being a little more.
Somebody can mute, maybe. Okay.
Oh, sorry. I think that might be. Sorry about that. So yeah, it's encouraged, but these are all guidelines. These are sort of trying to get to best practices, but it's also important for us to understand what some of the limitations may be to getting that done per shift.
So what do you propose what's the message? I mean, if the public is getting the message that we should be testing all of our, I mean, the federal government has decided that, it's recommended that nursing homes do point prevalence testing and test everybody and then do 3, every week. And looking at us and saying, so why aren't you doing this?
So now you're moving from the symptom question to the testing question.
Yeah. Yeah. So, I mean, what do we say? Oh, no, we're not following the federal guidelines.
Yeah. And that's something.
You have to say something better than that, right?
Yeah. And you can take my presentation today as the official word from HDOH. We're not asking that people do that baseline and weekly testing just as a blanket policy right now. There may be situations where it would be appropriate to do that, and that might be with a case that results in a cluster in a facility. Then certainly, yes, weekly testing in a cluster situation makes sense. But with our current prevalence being, looking at our positive rates across the state and even by island, we're all below 1% positive testing rates and well below that in some islands. It's just the yield of that is going to be very low right now. One thing we will work on as a department is to, look ahead prospectively and try to give signals to you guys and the community when things are changing and what would be a time when we would move to more of that stance. And so that is something that DOH would give guidance on as things change. But right now, as we monitor, and what I was trying to show you in these slides are the kinds of things we monitor to make those determinations. And right now, we're sort of putting us all in the zone of there's not a lot of community risk. It's not a stance that makes sense for Hawaii right now, but that could change in the future.
We have another question. To clarify, regarding resident and staff line listing, are we supposed to send into DOH via tele-ICAR weekly only if we have an outbreak, or if they're suspected COVID-19? When do we send in tele-ICAR?
When you say tele-ICAR data, so there's like the symptom logs that you're keeping. We have not yet figured out the best way to kind of keep ongoing monitoring that feeds into the state. So more to come on that. We're definitely doing it for facilities that have a case. And so you can expect us to be asking to see your symptom logs on a periodic, regular basis while we're still in that monitoring period. I think we need to figure out, because a lot of it is kept on paper at different facilities, so we're still kind of working through the best way to keep tabs without excessive paperwork. So more to come on that, and we should have updates in the coming weeks.
Okay, great. Any other questions?
Sure.
All right, I know Dr. Altman has.
Two questions about the working of in the Department of Health and the epidemiology surveying. One of them is what's kind of your working number for the percentage of asymptomatic infection in the state? Like a working, I know again it's hard to get a handle on it, but maybe a working number that you use. And the second question is a broad question. To what do you attribute the low prevalence in the state of Hawaii, where we have lots of tourists and we're close to Asia? And is it true that the infection went from Asia to the East Coast of the United States and then came here, or that there's some sort of mutation across the country, or like why is it that it's not a higher prevalence in the state of Hawaii?
Mm-hmm. So first question on asymptomatic infection. It's difficult to answer from the investigation data because the asymptomatic category actually encompasses a lot of different categories into one. So there's asymptomatic in household settings where people are tested because they're close contacts. And certainly we do see asymptomatic infections in large households. Probably about a 10% rate, but that may be, some of those people never go on to develop infection, never transmit the infection. And what does that really mean? It means that you certainly were around somebody shedding virus, but how did it impact you? And were you capable of transmitting it to someone else? We don't know. There's also asymptomatic infection from some of our healthcare situations, but is it really asymptomatic? It's more that in patients who are in chronic care, dementia can be more difficult to determine what their symptoms actually are, right? And so going back in our investigations, it's sometimes unclear, maybe this person did have a symptom, does that count as a symptom? And so it can be difficult to tell for some of the hospitalized patients. And then there's categories of people who are asymptomatic when they were detected, but were actually pre-symptomatic and then go on to develop infection. And some of those people, I think that's where the national studies are showing the high risk of asymptomatic transmission, but it's not really asymptomatic, it's like pre-symptomatic transmission. And so I think both we in Hawaii and our national partners are still trying to tease out the asymptomatic data to interpret it and understand what it really means. As far as why we haven't had higher rates in Hawaii, I still think the biggest answer that we can give right now is just that things were shut down really quickly here as soon as we began to have cases. And so that, both in terms of travel and then stay-at-home orders. So there was very little opportunity for spread. I don't feel like we have enough data to say that there's something different yet about Hawaii in particular. I know there's some interesting theories about climate and factors like that, but we just haven't seen enough disease here yet, and I hope we don't, to be able to answer those questions very well.
Okay, we have a question. Wanted to also clarify the definition of an outbreak. We received guidance to report to DOH for positive or clusters of COVID-like illness, which is 2 or more persons who reside or work on the same unit or floor presenting with new onset respiratory illness within the same 2-week period. Is this still accurate? I mean, I would think you don't even want to wait for a cluster. One case you want to, is that?
One case is required reporting. So one case is urgently reportable in a staff, a resident, a visitor. Report immediately. Don't wait for a cluster. I think talking about clusters is very valuable when you don't yet have testing data. So let's say the scenario would be you realize, patient A on this unit has woke up with a cough this morning, and now the next day patient B next door also has a cough. So that's potentially a cluster and worth calling about. It may seem like a small thing, better to have overcalled it, discussed it, figure out if we needed to test and resolve that than to wait and then have patient C and D have cough develop the next 2 days. So that's sort of where we're talking about cluster. What is an outbreak? A cluster becomes an outbreak when there's evidence of transmission. So the cluster is sort of a word that we use when we are still investigating and we don't know if transmission actually happened, but it's a way to jump onto cases right away because that's a potential cluster, and look into it. And then it's once we have a better sense that yes, transmission occurred because we can see that they had close contact and there was no infection in that contact, that 2 cases can still be an outbreak. It's still a transmission event. We tend not to use that word for 2 cases because it's so alarmist, but technically speaking, that's an outbreak.
Okay, I want to raise a concern that I know that a lot of nursing homes and nursing home medical directors have, which is the question about, they want to be super careful. They don't want any cases from the hospital coming into a nursing home. And we have abundant testing. So the idea that, requiring 2 tests from the hospital prior to admission to a nursing home.
Yeah.
I know that's a real sensitive topic. And, it's hard to blame people for wanting to be extra cautious. So I wanted you to comment on that. And then sort of related to that, there was a question about, how soon, within 24, 48, or 72 hours of hospital discharge, which would be the better strategy?
Well, I will tell you from our guidance from DOH does not require any testing prior to transfer, and we don't make that a recommendation. And I'll tell you why. One part of it is the testing information that I was sharing today in the slides is that if you have somebody with no symptoms and no known exposure, then testing them is not really accomplishing much in terms of, if you tested 1,000 people like that, you're still going to see, they're going to be negative. They're going to be negative if you already have a low prevalence population, right? The other side of it is, let's say you do have a higher prevalence going on. And so you say, okay, well, now my test is more likely to be valuable. It's still the problem of those people who are incubating. So if you have somebody, you're trying to make sure they're safe, maybe they had unknown exposure in the community before they came into the hospital and now they're moving to your facility. You test them twice. It doesn't even really matter if it's 48 or 72 hours. You could test them twice and they're on day 2 and 3 of their incubation period. And then on day 5 is when they would have been positive. You're still going to miss them. And so I really worry about relying on any number of tests really to be a screening to guarantee that you're not going to have an incubating person come into your facility. The 2 tests is helpful when they've had known COVID disease, because then you already established they had COVID, and what you're looking for is clearance of the viral shedding. I actually think it's too sensitive for that situation because you're going to exclude a lot of people who are actually no longer infectious. And so our guidance has really been to focus on the time and symptom-based strategies. If you've had adequate time and symptoms are improved, that person can be believed to be non-infectious after 10 days. And so we really have moved away from the testing guidance from DOH, just thinking of it from that perspective. And that's our perspective on the 2 testing issue.
What if, I can understand with the low prevalence, but what if the prevalence in the community is high?
Well, that's exactly what I'm saying. Then do you really want to believe testing rather than having that graduated cohorting strategy? And that's where I really like that post-acute COVID unit cohorting strategy, because you're building an insurance policy in. You're not relying on the test, which can fail you no matter what. You're relying on your PPE, which we know works. And I think, from my perspective, that's really the safe way to go. Of course, it relies on us having adequate PPE supplies. I think from what we've understood as we're reaching out to facilities, we're in way better shape than we were a month ago. But if we still have facilities that are having trouble getting the PPE, they would need to institute that we would love to hear about it, because that's something we really need to fix while we have the luxury to do so.
Okay, great. You know, I just realized it's 3 o'clock. It's 3:04 and time just flew right by. So thank you so much for joining us. And I know we're going to be talking again in July or so. We're going to talk about COVID units and cohorting again. And we'll have an opportunity to ask more questions at that point. In the meantime, just want to let everybody know, remember that in order to get your CME or CEs, visit the website and complete the online evaluation form, use the link, and provide any comments that or questions or topics that you want to see in the future. And I think that's it, and we'll see you next week. Thank you.
Thank you.